Well, thanks everybody for joining. And so I'm going to talk about, one of our typical patients. And then hopefully, as we go through some of the things that we feel are pretty important to a good care of the patient, obviously in the hospital, but continuing the care that we all provide during our hospitalization and ensuring that that follow-up visit happens well, but also trying to ensure a lot of things that need to happen between the hospitalization and that follow-up visit, because there are a lot of things that we like to have happen and we want to have happen, but we're not always able to make that happen. So that's kind of my goal with what we're to get through today. And like I said, please feel free for anybody just to stop me during the case, but we'll keep pushing through here. All right, so we have a 46-year-old female mountain mama that I like to affectionately call, presents to our clinic, referred to us by a local cardiologist for further evaluation and consideration of other therapies for an ischemic cardiomyopathy. She has a past medical history significant for coronary artery disease, ischemic cardiomyopathy, diabetes, hypertension, depression, and obesity. So I think a pretty classic patient that we tend to see. And I think it's really important to note that this lady, she's pretty young when she got diagnosed with coronary disease. She was 42 years old, and which is not uncommon, unfortunately, for what we see around here. So, so she came in with a couple days worth of chest pain. This is when she was first diagnosed with coronary disease about 4 years ago. And finally she couldn't take it any longer. She was found to have an acute MI, anterior wall MI, and multivessel coronary disease. At that point, she underwent bypass surgery, and her ejection fraction at that time was 10%. And improved to 20% after revascularization for surgery. Obviously, she has a history of CABG. She had a biventricular ICD placed in 2015 after her ejection fraction didn't improve, and she had an underlying left bundle branch block. So the thought was, let's try to do resynchronization therapy with her to try to improve her symptoms. And she's had a lap cola. She used to smoke. She quit after she had her heart attack, but smoked a pack a day for about 20 years. Doesn't drink, doesn't do drugs. Husband works full-time as a mechanic. She's got 3 kids. She's disabled, and parents live close by. So all that's, you kind of want to know all this stuff. It sounds maybe somewhat overkill to understand that detail of the social history. But, if you have someone that's going to be going home and you're worried about what their care is going to be like when they get home, you really have to know, are they going to have insurance? Are they going to have things covered? So you have to ask those questions. Do they have help at home? Or, maybe her children were younger. If her children were younger, who's going to help her take care of her kids? So these are things that you want to ask about on admission, but also keeping all that in mind at the time of discharge so that you know what level of support you're going to need when you have discharge. And, she has family nearby that can be helpful, although they have a lot of medical conditions of their own, by her parents, so it may not be all that helpful when she gets home. So I think, this level of social history seems, crazy detailed. I think this is the kind of stuff you want to do really on most of your patients, because if they're coming into the hospital or even your clinic and you're not sure if you're going to have multiple medical problems, you want to make sure that you're going to be able to deliver the care you want to deliver by understanding all these details. So keep that in mind as we move along. So at the time she arrived to us, she's on a low dose of metoprolol, 12.5 milligrams daily. She's on Entresto at 24, 26 twice daily. She's on torsemide, 80 milligrams twice daily. You can see all the meds here. So she's on a diuretic on a couple different, most of the meds we want for heart failure directed care. and she can't take lisinopril because she had a cough. So, some important things to note from my standpoint on her, that's a really hefty dose of torsemide. Remember, you're talking, it's probably like 160 of Lasix twice a day when you're talking oral torsemide. So that's really, that's requiring a lot of meds at home. And so someone's pushed the dose enough to try to keep her fluid pretty stable and fluid. So she's coming now. She was seen with us. She saw us a couple weeks ago. She's back again. She has had worsening shortness of breath. We bumped her diuretics when she called us. Really didn't do a whole heck of a lot for her, and she's still short of breath. Still feels like she's pretty volume overloaded. So blood pressure's on the borderline here. So she's pretty low blood pressure, 85 over 45. She's got a heart rate of 110. Breathing fast. Her weight's up 13 pounds. She feels that it's all fluid weight. She's got significant jugular venous distension. She's got rails bilaterally, and she's got 3+ lower extremity edema. She's got good peripheral pulses. She doesn't look all that cold, but still pretty concerning that here you have someone who's got a lower blood pressure, up a ton of volume, breathing pretty heavily, and got a high heart rate, right? So this is someone when you see walk through the door, I'm very concerned about them, and I'm thinking I'm probably going to end up admitting them, which is what we did. So good news is, so she's got some labs on the day of admission. Sodium's 129. BUN and creatinine not horrible. BUN 31, creatinine's 1.4. A1C is good, 7.4. Not stellar, but not horrible either. She had an echo which shows an EF of 10%, a really dilated ventricle, and pretty significant mitral regurgitation. Chest X-ray really showed some mild vascular congestion, but really nothing else went on. Her EKG showed that she was biventricularly paced. We interrogated her device, and she's pacing 97% of the time, which is what we want. She's had some runs of ET, but it's never gotten shocked. Has not had any, hasn't needed a device to do any overdrive pacing, and she's not had any atrial fibrillation. So she had a left heart cath. It's been a while. She had some worsening symptoms, and we wanted to be sure that she had, didn't have any significant new disease that we could really correct the situation. So her lima to her LAD is patent. She has some mild disease in one of her other vein grafts, and one vein graft is occluded. And at that point, it felt like there was not going to be an intervention wasn't going to make a difference in what was going to turn her around. So we also got a right heart catheterization at the time. Filling pressures are up some. Her right atrial pressure was 14. If you remember, normal, we like to see less than 8. She has mild pulmonary hypertension, and she had a wedge pressure of 20. Normal wedge pressure we like to see below 10, so that's significantly elevated. Blood pressure in the cath lab was a little bit better than when we saw her, and 95 over 58. And she had a reduced cardiac output and index. So really important to see this. We think, okay, we're hopeful that we can make some things turn around pretty quickly. So got pretty aggressive with her during her hospitalization. Once we were able to get fluid off, we got about 8 liters. She felt a lot better. Had a little bit of increase in her BUN and creatinine, but acceptable. She X-ray looks better. Remember, her weight on admission was 198. We got her down to 183 at the time of discharge, and she was walking around pretty well without any need for oxygen. So let me ask you guys, Anything else that if you're seeing this lady in clinic, I mean, I'm going to go through some stuff, but if anybody's seeing her discharge, are there other things that you'd want to know from this hospitalization you'd like to see in the discharge summary, make it easier for you to take care of patients? Anything that jumps to anybody's mind that I can answer before we move on here? Okay. Well, I'm going to go through the stuff that I think is important, but I'm interested to see if other people are thinking otherwise when I do go through this. So, some things that we think about before anyone even leaves the hospital. We push really hard for people to be seen within 3 to 7 days. And really, to me, what determines that 3 or 7 is how sick are they, how worried am I when they're leaving that they're going to be readmitted, how worried am I that when they leave they're going to actually do things that I want them to do as far as take their medications. So those are the things that really, I want everybody seen within a week, but the ones that I push towards the 3-day mark over the 7-day mark are the people who are sicker when they come in. To me, she definitely falls into that sicker category. And she's someone who I would be working up probably for transplant. So I would be doing a little bit differently than you all, but because she's young, right? You have a 46-year-old with heart failure. In my mind, anybody under the age of 50 who has heart failure should be seeing a heart failure specialist. Now, I am a heart failure specialist, so that's sort of, maybe somewhat selfish on my end. But if someone's going to be a candidate for any kind of advanced therapies like LVAD or transplant, you don't want to wait till they're in the throes of being horrible to make that a referral. So we prefer to see them earlier. So when they leave the hospital, we either going to see them in our clinic or their primary cardiologist or their regular or their PCP, or some hospitals like our facility have specialty heart failure discharge clinics. So try to get everybody who leaves the hospital seen in that clinic. And that's really because you have a lot of resources available in those type of clinics that are not going to be available to most practitioners. Some things we also want to make sure that people are going to have all the medications that we want them to go on, want them to be able to have them at the time of discharge. We do what's called meds to beds. We have a pharmacy that delivers all. We send our patient all the prescriptions to our hospital pharmacy, our outpatient pharmacy. They bring them up to the patient. Have a pharmacist do counseling with all the medications, review all the medications with them before they leave the hospital. To me, that's the ideal situation, but that's not available to everybody. It could be. There's a lot of you could do some things with your hospital, and it's definitely doable. But it takes some work, and it takes someone to push the initiative for that to happen, especially at some of the smaller hospitals. But if you have at least a discharge pharmacy in your hospital, if it can't come right up to bedside, you can actually get the meds filled, and they can pick them up before they even leave the hospital. Or if they're going to go to a local pharmacy, I think you want to make sure you discharge the patient in time that they can actually pick up all their medications before they go home. You don't want to discharge someone home at 7 o'clock and their pharmacy closes at 7, and then now they're going to go home and not have any diuretic that night or any of their other medications. So I think it's really important to medications at time of discharge. A lot of things that can go into that make a really smooth transition to care. Again, I think the easiest is when the medications are delivered right to the patient at the bedside, when their family's there, where education can happen from a pharmacist or even from nursing, depending on what you're available, what you have available to you at your institution. And then second best, I think, is filling it in the hospital before they leave. It's a discharge pharmacy. And third is really, your local pharmacy. And, nothing against local pharmacy. I'm not trying to put them out of business. You can transition all the medications over to them. But what you don't want is someone missing out on, they may not have some of the meds that you send them on, especially if it's a smaller pharmacy and you're sending them home on Entresto. They may not have Entresto because Entresto is really expensive for them to stock. So those are things that you got to keep that in mind. With whatever you're sending someone home on, you got to know, is it easily available? Torsemide. Not every small pharmacy has torsemide. Most of them have Lasix, but they don't necessarily have torsemide. So a lot of those kind of things you got to keep in mind. We have a nurse navigator and a patient navigator at our institution that make phone calls within those first 72 hours. And we have them, there's basically a scripted call. They're asking if patients are actually doing their weights at home. Do they have their medications? If they didn't get them before they left. So did you get everything? Are you taking everything? There's a list of questions that we have, like so-called trigger questions. So if people are saying yes or no to certain things, that triggers a different phone call from the physician who was taking care of them during the hospitalization in their office. And they really want to verify the follow-up visit. Is it really going to happen? And are they coming? So we have a couple people do that. That's what I think, resources from a hospital standpoint, that's where most of this stuff comes from. It's not going to come from a primary care physician. You're not going to have those resources in the community necessarily. You want to make sure that that's kind of why hospitals try to provide all these services, because we all care about our readmission rates. We get penalized if we have higher heart failure readmission rates. That's a lot of the reasons that hospitals will want to pay for this, but the reason to do it is to provide good care and to make sure that the right things happen for your patients when they get home. So I think it's really important that we do all these things in some manner. I'm more than happy if anybody's interested in starting any of these type programs. We can walk you through what we did at our institution. We can do that anytime. So this is not as hard as you think it is to do, and you can use a lot of existing resources. You will need additional resources, but a lot of this stuff is very doable and should be done. Honestly, because it's just good care. So what about once they get home? What other things? So we just talked about all the important things that we need to have happen before they leave the hospital, so that we think that when they get home, they're going to be able to do all that. But they got to have the family support that I talked about. Are they going to need home health care? I think I'd love to have most of our patients have home nursing come if they need physical therapy or occupational therapy. Do you know if they're going home to a safe environment? If you've been to some of your patients' houses, if you ever do a home visit, you'll see that that's a lot of times it's crazy. A lot of them don't have running water, which is to me pretty amazing in 2019 in the United States. So again, you want to verify that they got their medications. We talked about that, but I know I say that over and over again, but the number one reason for someone to come back in the hospital is non-compliance with their medications or not getting their medications. So it's up there. Just right behind that is non-compliance with diet. So you want to make sure they're going to have a scale at home. We give every patient that leaves the hospital a scale if they don't have one, or if we haven't given them one before. Love for them to have a blood pressure cuff. We don't give every patient a blood pressure cuff, but I'd like to know what their blood pressures are, because that comes into play when they come to the office, and you want to try to adjust their medications. Pretty important. Phone, internet. A lot of people don't have either one of these, right? So they may have a cell phone, but they got to have some sort of way for us to be able to communicate with them. Do they have internet? Are they going to be able to use MyChart for those of us who are in the WVU system and have Epic? Are they, what other resources will they have if they want to look things up on their own? Can they do that? Do they know how to do that? Can they read? Lots of things like that. I think we take for granted when we discharge people, but not everybody has that available to them. And even if they do have internet, is it slow? I mean, I can tell you, even my own mother-in-law, she has DSL. It's really slow connectivity. And if they're going to have any type of video chat or anything like that, it makes it very difficult for them to have. So those are kind of things you want to make sure at least when they leave. It doesn't mean you're not going to fix that, but at least you know what their capabilities are and their limitations are when they go home. So what do we want to have at the follow-up visit immediately after discharge? So this is a 3 to 7 day follow-up. I have a lot of this stuff here that I think would be great, but also realizing that the majority of people are not going to have. So we have all that, anything at the staff in the clinic, that's what we have in our discharge clinic. So we have a physician and a nurse practitioner. We have a nurse coordinator that's going to be there for the patient to call when they after they leave and with any issues. We have an MA to help with things. We have a pharmacist, and again, a lot of this stems from trying to reduce readmissions with education. We have a dietitian in our office, and we have a social worker in our office. When they're leaving the hospital, the case manager is supposed to be helping with a lot of things, but a lot of things necessarily don't get addressed before they leave. They try to, but remember, your case manager's discharging a ton of patients. They can't. Sometimes everything is not able to be addressed before they leave. So we follow up on a lot of this stuff. So if they're unable to they have a hard time paying for the medications, is there assistance out there for them? Is there patient assistance network for expensive medications like Entresto? Some patients can't afford that. So we work on what we can do for that. So I think we do it, when I tell a patient they're coming to our discharge clinic, I prepare them for an extensive visit. I tell them they're going to be there for at least an hour because they're going to go through a lot of things, a lot of education. Because it's hard to absorb all the education you try to give someone when they're in the hospital and not feeling all that good. So when we do every hospital in the country to meet requirements. You check the boxes. Yes, I educated the patient. Yes, I gave them material. Yes, we talked to them about their medication. All that stuff. But it doesn't mean that when they've been in the hospital for 7 days, they're exhausted. They weren't sleeping because we're getting labs on them every 2 hours in the middle of the night. They don't necessarily absorb all the education you try, so you want to make sure that you get that education in again when they come back for their follow-up. And you have a captive audience. When they come back in, they're feeling better, and they want to stay feeling better. So now's the time to really try to hammer home all that stuff. So if you can, great. If you cannot, at least try to get some of that education in and make sure we verify what they're doing. And if you feel that they're in need of more stuff, we're more than happy to see them, or even just to have a pharmacist call them, or a dietitian call them. I think working that out is not that, it's a challenge, but it's doable. But what about, visit essentials? So you need to have a good discharge summary. So that's why it's really important to do a good discharge summary. But you need all the details of medication changes during the hospital. So what did they come in on? What did they come out on? Those sorts of things are really important, is what changes, And, it's really important to say, okay, I have all of my patients bring all their medications with them. Because sometimes when you make those med changes in the hospital, even though you tell them to stop taking other medications, they're taking both. They're taking what you put them on, what they were on when they came in, and what you put them on when they left. So I think it's really important to have them bring their medications with them, not just a list of things. You'd be surprised what you find out. You got to get a good blood pressure at the time. Remember we talked about the blood pressure when this lady was admitted. It was low. What was it when she left the hospital? Because you're going to want to know what it was. Maybe you can't get into the hospital records when you're seeing in your clinic. So I think that's important to have in your discharge summary, is what it was when they were admitted, what happened when it was when they were discharged. And so when all the medications they left on. So you're looking at their medications, like, why aren't they on this? Why aren't they on that? Well, if you see a blood pressure was borderline, then you're going to understand a lot clearer as to why they're not necessarily on all the medications that you would want them on. So you want to wait. So I told you she lost 13 pounds during her hospitalization. That's going to be really important to say in your discharge summary. And I think that's something you have something to compare it to, when you see them in the office. Yeah, I know the scales are different, but at least you have somewhere to go with, something to go with. We'll know what their heart rate is, their SATs. We talked about how she was able to ambulate without any oxygen or anything like that. And, I think it's really important to document their New York Heart Association classification. What were they able to do when they left the hospital? We know what she was when she came in. She couldn't do anything. And we said she's really active. So, was she class 2 or class 3? These are things that you want to be able to, sounds like she was class 2 when she left. So we want to document that. And you want to document that in your note when you see her in that follow-up visit, so that when you see her the next time, you're able to document that again. And you have something to go back to compare that to. I think trends are really important in care of our patients. So, and especially with weights, blood pressures, meds, heart rate, you get all those kind of trends that you can get just from an office visit and from their hospitalization. You don't have to have fancy devices to get some of that. You just have to have decent documentation. So I think it's really important that you do all that stuff, and try to make the best. If the best documentation that you can do tends to give you better care once they leave. So, okay, what other things we need to consider when they're at the visit? So we looked at them, we examined them, we went through all the stuff. Are they compliant? I don't know. Do they have all their medications? They take them correctly? A lot of stuff I just talked about. Are you going to make any changes? So if we're particularly talking about reduced ejection fraction, with an ejection fraction less than 40%, we have gold dosages. We know that we have gold doses of each of our medications. For example, lisinopril, gold dose of lisinopril is 20 milligrams total in a day. Are we there? Do we have blood pressure room to get there? Are they on a beta blocker? If they weren't on a beta blocker when they left the hospital, why weren't they? We'd like to get them on one, or make sure we use an evidence-based beta blocker, like she was on metoprolol succinate or toprol. Can we go up on that? The gold dose of toprol is 200 milligrams. She was on 12 and a half. So what about an aldosterone antagonist? Was she on spironolactone or not? She doesn't have AFib, but if someone did, are they on anticoagulation? Is there a reason they're not on anticoagulation? All these things that you can address when you have them capture at the hospital visit, you want to push. You're not going to fix everything at this visit, but you can give goals for each one of these things. So if they're on an ACE, or if they're on an ARB, or if they're on an ARNI like Entresto, or if they're on a beta blocker like toprol or Coreg, or again spironolactone or Clarinone for aldosterone antagonists, or do they have AFib? Are they on Coumadin? Should you change them over to a NOAC like Doxaban or Pixaban? Any of those ones? Do we need to change them over? Again, you have them there. They're attentive. You want to be sure you're looking at all these things, because this stuff's really important. And then, do they have any barriers? Did we find any barriers at this, at the time of discharge or at this visit, that really that caused your discharge care to be less effective than they should have been, and we didn't notice it during their hospitalization? Did they get home care? Did they not get home care? If they need home care, can we make it happen? Remember, they have to be considered homebound if you're Medicare to be able to get home care. That means that basically all you do have to document is that it's very difficult for them to get out of the house to the doctor's office and to do other things because of their illness, and it's pretty easy to document from a heart failure standpoint. You can usually make that happen pretty easily. But if they need it, are they getting it? Are they refusing it? Why are they refusing it? A lot of these patients don't want anybody in their house because they're embarrassed by what's going on in their house. So these are things that I think are really important to follow up on when you're talking to them in the office. And so I think other things. When are they coming back? Are they sick enough that you want to see them, more often, or are you going to see them in a month? I mean, this lady, for me, I'd probably see her weekly for a month, because she was just in. She was really on the borderline of being in cardiogenic shock, and I'd say, in our office, I'd tell our nurse practitioners, let's bring her back weekly, make sure for the first month, and then we can spread it out after that. Remember, you want to keep her out of the hospital from a quality standpoint. You want to try to keep her out of the hospital for 30 days. And that's because that's what you're getting judged on. What's your 30-day readmission rate? So if you think she's on the borderline and you think that you need to have close follow-up, then you need to do that on a weekly basis. You want to make sure they get labs. What's their kidney function? We looked about her kidney function. At the time of discharge, was already up a little bit. Her BUN was 40 and her creatinine was 1.6. So where is it now? You sent her home on a decent amount of diuretics. Do we need to change the diuretics? Is her weight different in this office visit? So those are things. How often are you going to get labs? Is the potassium level high, low, good, bad? We'd get labs sometimes twice a week if we're adjusting diuretics and potassium, just to make sure that we keep potassium levels okay. Because last thing you want to do, you're doing great from a heart failure standpoint, and all of a sudden they get shocked by their defibrillator because their potassium is 2.8. Right? You want to make sure you want to follow up on all those things. Or if you're not on spironolactone, you add spironolactone, where's potassium going to go too high? You got to make sure that you follow that too. So I would say, most people who are, at least, a couple times in the first month that you want to see them. So again, depending on how sick they are, do they need to see just the PCP if they're seeing you all in the office? Do they need to see a cardiologist? Do they need to see a heart failure specialist? If you don't have a pharmacist or dietitian, does that need to happen? How do you make that happen? These are all things that you want to try to push as you move forward. And if you don't have those resources, you want those, and you can call me or my team anytime. We can absolutely help with a lot of these things. I think there's opportunities for telemedicine to be a part of these sorts of things with pharmacists and dietitians. So I think all these things are really important to follow up on the details are really again detail oriented. You got to know the labs, you got to know the meds, you got to know the changes and all that. You got to know the weights, you got to know where that's going, and the patient's got to know that they need to call you if there's a change in their weight. Don't wait. If you felt that they were okay, and you're going to bring them back in 3 or 4 weeks. Patients need to know it's not okay to wait 3 or 4 weeks. So they start gaining 4 or 5 pounds, they need to call back so we can make adjustments in their medication so that that's okay. And when you got to give them that information when they leave the hospital. What's the number to call if you start seeing this before you get to the follow-up visit? They need to know who to talk to for that. So all that stuff's really important. That's a lot of long-winded talking for me, and a ton of info. I wanted to limit it to that, and that's why I didn't go into much more detail with the case, because I wanted to allow some time for everybody to kind of ask questions or give some feedback of what you think is doable and not doable. But there's a lot of things that we can do without additional resources, and some things you'll need additional resources to be able to do. Questions?
Awesome. Thank you, Dr. Sokos. I'm going to stop sharing your screen real quick and let people ask some questions.
Hello. Dr. Sokos, could you speak a little bit about Colonor and its utility in heart failure?
Sure. I think so. Colonor is supposed to be. I think it's a difficult drug. I think in order to because you want to make sure you're going to use it in patients who don't have AFib and patients you're trying to reduce their heart rate somewhat, but they typically need to be maximized on their beta blocker before you use Colonor. That's what that drug is indicated for. And that drug was approved because it reduced hospitalizations in patients with heart failure. And I think it's a drug that we use, but somewhat sparingly, because we're really fighting to get onto optimal doses of everything else first. Because when that drug was studied, it was when optimal use of an ACE inhibitor and beta blocker as background therapy. So it's not that we never use it. It's just that I think it's there's a use for it, but it's just definitely not as broad as our other agents. Anybody else?
I'll ask real quick and let some people think, but when you have a patient discharge coordinator or somebody, do they give the patients a packet of information they can pass along to their primary care physician or somebody else who they need to coordinate care with? I think we've all seen patients whose health literacy is questionable, and it's hard to relay that information when you're moving through people.
Their own packet of information of what their discharge information to them that we encourage them to take to their follow-up visit.
Mm-hmm.
We also want to make sure that we get we do send the discharge summary from the hospital to their take care of them. I think it's twofold. They have in their hand from the time between discharge when they actually get to their follow-up visit, so that someone, let's say home care is coming in, they should have that information available to them as well.
Awesome. That's great. Do you guys have any other questions? I know some people jumped on a little late, but you guys can definitely watch this when I post it on YouTube. I'll share the link with you. You guys can forward any questions to me and I'll get them to Dr. Sokos. All good. Dr. Sokos, do you have anything else you want to add?
No, I think if anybody has any questions, or if anybody out there would ever want to spend any time in our clinic to see how we do some of the things, I'm more than talking about it's one thing, but seeing how it actually all works, or if there's any nurses or nurse navigators who want to spend some time with our nurse navigators, see how we do things at Discharge, happy to provide that. Or if there's things that maybe you all think you do better than we're doing, I'm happy to hear about that too. Because we can definitely improve what we're doing. Happy to take any input.
Excellent. Thank you all. We'll see you guys again in 2 weeks. Thank you, Dr. Sokos.
Thank you.